So, hey guys, Professor Costa, and I'm back with part two of our metabolism lecture. So, let's look at causes of DKA. Okay, and the biggest cause, the number one thing that starts this whole thing rolling is a lack of insulin, right? So, an environmental stressor, an infection, an emotional stressor, or a new onset of diabetes, we're going to have a lack of insulin. And a mismanagement of DM can also cause this. So there are some folks, unfortunately, in today's day and age, there are a lot of pharmaceutical companies that rebranded some of their insulin types, and it drove the price up exponentially. So people that were using brands of insulin for years suddenly found themselves having to pay hundreds of dollars out of pocket for something they need to stay alive. And there was some rationing that happened. And in fact, there was a case where a younger adult, he had lost his insurance from his parents and ended up rationing insulin, and then he died. So lack of insulin or a mismanagement of diabetes, skipping insulin, can cause DKA, and it's a sudden onset, right? Patient illness. So remember the stress response, what that does to glucose levels. So sometimes it's just too much sugar for what we do have available in insulin to adequately cover. So patient illness. So hyperglycemia from the stress response without adequate insulin coverage can also lead us into DKA. So our type 1 diabetics will have really strict sick day rules where they're taking their blood sugars quite frequently to prevent this potentially deadly complication from occurring. And it does most often. And for your purposes of testing, I want you to just think that DKA is a complication of type 1 diabetes. All right. So with that lack of insulin, we're going to have hyperglycemia. We're going to have osmotic diuresis, where our body is just urinating out all of this fluid, and electrolytes are going to go out with that. Then we're going to have an acidosis from the breakdown of fat that our body's using as an alternate fuel source. And we're also going to have some protein catabolism too, which gives us an increased BUN. So their electrolytes are all going to be off. They're going to be dry as a bone. They're going to have hyperglycemia, and it's very, very scary. We can have severe electrolyte abnormalities, arrhythmias, and this can lead to coma and then death. So clinical manifestations is a severe fluid deficit. When I say severe, I mean they are really, really dry. So signs of dehydration, including tenting skin, tachycardia, sunken eyes. Remember what the heart does when it sees a decrease in its own source of nutrients and on oxygen. If it sees a drop in O2 or perfusion to itself, it will increase its heart rate trying to increase production. And unfortunately, that's going to lead to some problems with these patients. Metabolic acidosis, hyperglycemia, electrolyte abnormalities. So if we have an acidosis, the natural compensatory mechanism of the body is when we have an acidosis, it will try to decrease the amount of CO2 available by breathing it out. So our respirations go up. So a Kussmaul respiration is fast and deep. And what happens is with the severe hyperglycemia and the ketones, these patients can have like a fruity breath. It smells to me more like fresh baked bread, but the classic description of it is fruity. Nausea, vomiting, and abdominal pain. They can be so hyperglycemic, and without the cells are starving without being able to use that sugar. When we don't have insulin, that's going to lead to coma, because remember, the brain relies on glucose metabolism to stay alive. The three P's: polydipsia, polyuria, polyphagia, right? So they're thirsty, they're peeing everything out, and they're starving to death, literally, and so they're going to feel hungry. So here's just a reminder of what Kussmaul respiration. So it's that fruity acetone breath, an increase in rate and depth. It's fast and deep. In terms of an ABG, your body is trying to blow off CO2 in an attempt to correct the pH. All right. So medical management, this would be a slide I would know. So medical management of DKA. All right, so fluids. Remember, we have severe fluid deficit. So we are going to need fluid boluses. And usually we're going to use normal saline, 0.9% sodium chloride, okay? And always, though, whenever we're fluid resuscitate anyone, we want to watch for signs of CHF or pulmonary edema. They may even, a lot of these patients get cared for at the very least on a progressive care unit or step down. Most often, if it's a severe enough case, they're going to be on a monitored unit like an ICU. They may place a central line and do CVP monitoring, though not always necessary. Electrolyte repletion, so potassium and sodium. Hypokalemia is the leading cause of death from DKA. All right, so remember on that other slide where I talked about the concentrations. So concentrations greater than 10 milliequivalents, or it's actually, I forget the number on the bag, but we don't want to give them the 10 milliequivalent, anything higher than a 10 milliequivalent bag. We don't want that in the 20s. We don't want those in a peripheral line. We want them in a central line. I know I didn't say that very well. It's written on the slide. Potassium repletion with either intermittent infusions of potassium chloride or through addition of potassium to maintenance fluid, right? So usually they'll start this 1 to 2 hours after the insulin started and when the potassium levels are below 5, okay? So we're going to start repleting them, but usually we want the insulin started so that, because most of the time, they come in with a high potassium because of that leak, though sometimes they come in with a low potassium because they've been sick for a really long time. What I'm saying is we're going to monitor those K levels really carefully. If they come in with a high K, we're going to start the insulin, and then once it gets below 5, then we'll start repleting them. We don't want to jump them up to a 6 or a 7 and kill them. Medication, so continuous regular insulin infusion. This is one of those absolutes in the world of nursing. There's very few absolutes, okay? And this is one of them. The only, and I'm going to repeat this, the only type of insulin that can be administered intravenously is regular insulin. That's it. You can't give any other kind of insulin except regular insulin by IV, all right? I guarantee you will see a question about this at some point during the semester, all right? And if you have an insulin drip, a continuous insulin infusion, you should have a dedicated IV line. So if you're fortunate enough, you have a triple lumen, one of those lumens should be dedicated to the delivery of insulin, all right? If you don't, you have peripheral IV, then a lot of times they will start a second line just for the insulin, all right? Q1 blood glucose measurements in the acute phase. So I tell those patients, buckle up, buttercup. We're going to be taking your blood sugar every hour. I'm so sorry. You're not going to get much sleep tonight. Do not start the insulin if their serum potassium is already below 3.5. Like I said, if they've been sick for a really long time, their K may be so low that they can't even manage to be hyperkalemic even without the pump working. So if their potassium is already critically low, then we want to give them repletion potassium before we start the insulin, all right? Because we might start that insulin, bottom them out, and then they arrest, which would be an awful thing. Also, we have a severe acidosis. If the pH is creeping towards 7, we may add bicarbonate. So we may administer bicarb just for the severe acidosis. All right. So laboratory and diagnostic testing for this patient's frequent serum electrolyte levels. So we are going to be checking their lights frequently, every 2, every 4, every 6. It depends on the provider, but be ready to be sending off electrolytes and get ready for the phone call from the lab when they tell you that it's a critical value. It happens quite often. So a BMP, or some facilities it's known as a Chem7, a magnesium level, a phosphorus level, an anion gap, a venous gas. So it's like we're getting a pH and all that off of a venous blood or regular blood. Sometimes if your patient has a central line, we'll draw a venous gas because we're looking for pH, and we don't want to keep stabbing the person in their radial artery. It hurts to have an ABG drawn. So if they have a central line, they'll often do a venous gas or an ABG, right? Continuous cardiac monitoring, right? We want to watch our strip carefully to make sure we don't have any funky lines, or this patient's pretty sick. We can have they could be so dry that they could have a demand MI. We don't know, right? Or they could go no arrhythmia from one of the electrolyte abnormalities. Here's my little tip from a pro. Arguments for placement of a central line would be really high. So if you're getting that patient into the emergency department as the ER nurse, that would be when you would mention it to the doctor that this patient is going to have complex medical management, lots of IV medication, potassium repletion. Remember, we can give more potassium over an hour through a central line than we can in a peripheral. So we would argue for our patient's benefit that perhaps they should place a central line for this particular hospitalization. ICU level of care, absolutely ICU level of care. Okay, so lab values associated with DKA. So blood glucose, they're going to be hyperglycemic, right? They're going to be acidotic, so their pH will be less than 7.30 or 7. They'll be acidotic. An anion gap would be greater than 10. So they're just taking the sodium levels, the chloride, the bicarb. They do the math, and if there's a gap greater than 10. So for instance, for a sodium level of 140, a chloride level of 102, and a bicarb of 25, they're going to take the positively charged one, which is the sodium, and then they're going to subtract the negatives, the chloride and the bicarb, and you'll see the math. It's 13. So if the anion gap is higher than 10, then that's a bad thing. That means they're probably in DKA. Serum bicarb. So as the body becomes more acidotic, the bicarb level is going to adjust as well. Urinalysis, there's ketones. It's diabetic ketoacidosis, and those ketones and glucose are there. The ketones are there because your body is resorting to using not clean energy. It's using fat and protein and all this, trying to stay alive. Glucose metabolism is clean energy, but we're not using that. So we're going to have ketones in our UA, and those aren't normal, okay? And we're going to have sugar present. Remember, sugar is not normally present in urine either. And then, oftentimes the serum creatinine will be elevated. Sometimes the sodium will be normal, or they could look like they're dry. The potassium, remember, often elevated or normal, but overall they have a deficit. They may even have a mildly elevated white cell count because of the stress response, or many times patients go into DKA because they're already sick with something else. So how do we resolve? How do we know this is getting better? How do we know we're fixing this guy or gal? So the labs are normalizing, so our blood glucose level becomes less than 200. The anion gap lowers, goes below 10. The pH normalizes and our bicarb normalizes. That's how we know. Our next topic is HHNKS, or hyperglycemic hyperosmolar non-ketotic state. Sometimes it's also called HHS because they want, HHNKS is a little long, right? So they may call it hyperglycemic hyperosmotic state. All right. The key word, though, and I like to keep the full abbreviation, is the non-ketotic state. It's different, all right? So I want you to think about this as occurring with people with type 2 diabetes, all right? Generally speaking, this is a problem with type 2 diabetics, whereas DKA is a problem of type 1 diabetics. HHNKS is with type 2 diabetics. So it's similar, but where the cells aren't in a desperate need of sugar. Remember, type 2 diabetes deals a lot with insulin resistance, but for the most part, the cells still make the islets still make insulin. The cells don't use them very well. So we don't have the ketones present because the body is still able to use glucose metabolism, but it's not doing a very good job of managing the hyperglycemia. So these patients will have severe hyperglycemia, like sugars over 1,000, which is kind of cool to see on a lab report, but not in real life with a person. So it's similar to DKA, but patients still have some of their own endogenous insulin. So the metabolism isn't affected as much. So we don't have as severe issues with potassium. We do have electrolyte abnormalities because remember, we still have hyperglycemia, and that sugar is going to still get spilled out, and they're going to have polyuria and polydipsia. So we still have the same dehydration, the same hyperglycemia, and we do have some electrolyte imbalances, but we don't see the ketones or the severe acidosis. All right, so they're not going to be breaking down all those fatty acids, and they're not going to have ketones present. So they will still need electrolyte repletion. They will still be really, really dry, and they're going to need fluids, and they're still going to have severe hyperglycemia. All right. So, and this happens more slowly. This is I'll tell my story. My oldest friend in the universe, her husband, my kids call him Uncle John. So Uncle John doesn't do very well going to the doctor. In fact, he avoids it like the plague. Like he really didn't even want to go to the hospital when his wife had their kids. Like he hates being anywhere close to a hospital or medical. So he's not the best eater, and you could tell that he was probably going to be, a type 2 diabetic. Anyway, he ignored all the signs. He was getting up to urinate, he wasn't feeling well. And it wasn't until his vision started to be funny that he finally, and he couldn't go to, drive, or like suddenly his vision got funky. So his wife is actually a very intelligent person, and she works in a medical office. And so she took him to the hospital, against his wishes. And they did an A1C, and it was like 15 or 16. It was ridiculously high. His sugar was over 1,000, and he was in HHNKS. All right. So we know that this is a critical care patient. This patient is severely dehydrated, has severe hyperglycemia, has electrolyte imbalances, and needs ICU level of care. But they didn't know John very well. So Uncle John left, said, nope, I'm going home. And so the doctor, in a desperate plea to save his life, said, all right, let me start you on metformin. I'll start you on this, and here are some potassium supplements, and hopefully you stay alive. And the doctor actually called him at home the next day to see if he had made it through the night. And he did, stubborn as he is. And he now takes his metformin every day. And somehow he managed to live through this. Amazing, but true. But, was that the best thing for Uncle John? No. He should have stayed in the hospital and been rehydrated and not given his wife the scare of her life. But just so you know, that wouldn't have happened. Like a DKA patient would have been way more severe, more likely of them dying from that. But this happens more slowly. This didn't just happen overnight. DKA happens really, really quickly. This happens over a period of time. So patients with type 2 diabetes are more likely to have issues with perfusion related to the chronic effects of diabetes on their blood vessels and lipid profiles. Remember, insulin not only helps us metabolize glucose, which we need to stay alive, but it also helps us store our lipids out of the bloodstream where they're taking up our endothelial lining and causing plaque and all that. So if you are a type 2 diabetic and you're not managing your sugar very well, then you're not managing your lipids very well either. And and because of that, with the hyperglycemia, so the sugar's causing damage, the lipids are causing plaque. It's just garbage, right? We need a cleaner road to deliver our nutrients, and these people don't have them. So they're more likely to have chronic effects on their blood vessels and lipid profiles. Acute changes in mentation or seizures can be seen with HHNKS too. Don't forget, our brain likes to metabolize sugar, and all of these abnormalities aren't very good for our brain either. The gradual onset can lead to patients not recognizing they're ill until they are very sick, just like Uncle John. Like he was able to, denial is a very easy thing to do, and he was able to deny that until his eyes were affected. And then kidney damage can vary based on how long the patient has been ill. All right. So here's our little comparison sheet. So DKA, usually type 1 diabetics, a serum glucose of at least 300, acidosis is present, and ketones are positive. Okay, when we do a urine test, they are going to have positive ketones. HHNKS is usually a type 2 diabetic, and they're shooting for at least 600. I've seen sugars over 1,000 easily. The pH is usually normal, however, because they're not using those fatty acids to stay alive. And the ketones are negative. So now we're going to talk about monitoring for severe hypoglycemia. When we have, usually we're so worried about controlling people's sugars and keeping their sugars low that we forget that we can have too much of a good thing. So severe hypoglycemia is when our insulin injection or infusions are too much, right? And we've overdone it. When you have a continuous IV infusion, that's why we do those glucose measurements every 1 to 2 hours, just to make sure we're not heading towards severe hypoglycemia. So always monitor for signs and symptoms of hypoglycemia. And these aren't new. Dizzy, shaky, anxious, sweaty, confusion, weakness, grouchy, coma. Okay. When I was a CNA, I'll never forget, I had this really, really funny, nice lady. And it was the PM shift. And I had been joking around with her. And she was a hot ticket. Anyway, she was admitted for management of her diabetes, and so they had adjusted her insulin sliding scale just before dinner. So they'd given her new higher dose, and then we brought in her dinner. So I'll never forget, she was eating spaghetti, and suddenly she turned into, for want of a better, just a really nasty. She just got really, really grumpy, and she snapped at me. And even though I was a CNA, I was like, so I ran and I, grabbed my, nurse that I was working with, and they took a sugar, and it was like 30 something. So, and luckily she had her dinner in front of her, and we gave her some juice. But mood changes or grouchiness can be an early symptom of hypoglycemia, because she wasn't sweaty or shaky or anything. She just turned on a dime and went from being so sweet to really, really cranky. So here are the signs. You know this. This isn't new material. You've been in 1020. You know that we're going to test you on signs of hypoglycemia. Why do we want to know that you know the signs? 1, so you can see it in your patient, and 2, so you can teach your patient and their family on how to monitor this. So most sliding scales, so most patients that are insulin have a protocol already in place, and it varies from facility to facility. But most of them, it's a blood glucose below a certain value, either 60 or 70, or they're symptomatic. If your patient is starting to lose consciousness and their sugar is 71, guess what? You're still going to treat it because they're symptomatic. Not everybody is, exactly less than a 70. So there is usually a lower sugar, or the patient is symptomatic. If you have them on an insulin infusion, you're going to shut off the infusion. And then per agency protocol, right? So if they're able to eat and they're still awake, then we're going to follow those rules of 15, just like Professor Gomes used to teach. So, if they're awake and they can eat, then we're going to get them some juice or some soda or milk. Or if they're not awake, we're either going to do IV dextrose, or we're going to do glucagon, right? So glucose works a little faster, but glucagon can be given without an IV. But we want to repeat the blood glucose level in 15 minutes. So the rule of 15. So if they can eat or drink, we're going to give them some juice. If they can't, we're going to give them something IV or sub-Q. But we're going to fix it, because if we don't fix it, then they're going to become unresponsive if they're not already. So a glucagon kit. So not everybody who's a diabetic walks around with an IV all the time, right? So that's the beauty of glucagon is it can be given by injection and it does work quite fast. There's also the glucose tablets or the gel that patients will keep with them, and you can squirt the gel in the buccal gel. You can put it in their gum line and they'll absorb some of the sugar. And the thing about glucagon is it's not stable once mixed. So the kit comes with the diluent pulled up in the syringe already, and then you're going to mix that. And if you see the pictures on the screen, you'll see that it gives them directions. And it's not a hard injection to give. All right. So glucagon is a hormone that causes the liver to release glucose into the blood, and it's used to quickly increase blood glucose levels in diabetics with low blood sugar, right? Insulin helps the cells absorb glucose, reducing blood sugar and providing the cell with energy. And glucagon instructs the liver to release stored glucose, which causes blood sugars to rise. So glucagon is the yin to insulin's yang, or vice versa. So remember, for every positive, there's a negative, and glucagon is the opposite actor of insulin. And so we can give that in a hurry to raise glucose levels. Islet cells in the pancreas are responsible for releasing both insulin and glucagon. So further patient education. Diet and nutritional consults. So these patients often need to meet with a dietitian. If you have a patient that is frequently going into HHNKS, or you have a type 1 diabetic that's had multiple bouts of DKA, they need to be working with a dietitian. And they also need to start monitoring themselves better. Checking their urine for ketones when they're ill. You literally just pee on the stick and then compare the number. And monitoring blood sugar levels. I know you know this, but there's so many people walking around with diabetes that don't even check their sugars every day, which amazes me, except that those little AccuCheck or the glucometer strips, they'll give the insurance companies or the glucometer companies will give you the glucometer for free, and where they get you is the price of the strips. It can be very, very expensive to check your blood sugar, okay?